Okay, so hello everyone. My name is Daniel. I'm a fourth year medical student and I'm the co-founder of the USMLE Forum of Pakistan. In this podcast, we're gonna talk about something regarding family medicine, and I'm gonna give you few basic clinical principles, and those are my golden principles. And I'm damn sure if you stick to those principles, you're gonna ace in your shelf exam, in your ward test, whatever you say. But those principles are literally golden principles, and I have made them by myself. I've gone through literature sometimes. I've gone through some forms, and then I designed those basic principles literally. So let's start. But let me tell you that if you are applying for any exam, and even if you are a clinician, just watch this video. It is very useful for you. It is full of knowledge, and it's very great. I can assure you that you will end up getting a lot of knowledge, a lot of beneficial knowledge at the end of this video. Awesome. So, first of all, my first golden principle. First, suppose if you are in the clinic and if you got a patient with monoarthritis, you know what is monoarthritis is, and upon the examination you see warmth and swallowing as well as pain on his on his knee. Let's suppose knee, if we're talking about knee, and also you see fever. The patient is feverish. He is having some temperature of 101 degree Fahrenheit or something like that. Awesome. Now, what will be the best next step in management? You will do arthrocentesis. Always aspirate the joint in the patient with fever, monoarthritis, and having some swelling and having some erythematous or reddish joint. Right. So that's my golden principle. Another thing. Now, a patient comes to you and she has just started vegan diet, and she's stick to the vegan diet. She's taking vitamin B12 supplementations from an exogenous source. Now, which mineral or which you can say iron will be deficient in the patient? Okay, she's following strictly vegan diet, okay, and she's taking vitamin B12 supplementations. Now, let me tell you, she's also taking vitamin D, so you can say that she's taking some multivitamins. Now, which mineral will be deficient in this patient? Let me give you some basic points. In the vegan diet, if someone is following vegan diet, then then she might be deficient in vitamin B12. She or he, mostly females follow vegan diet, so the patient might be deficient in vitamin B12. The patient might be deficient in vitamin D. The patient might be deficient in calcium. The patient might be deficient in iron, and the patient might be deficient in zinc as well. Right? So these are some important ions and minerals that you should never forget, especially in the clinical setting. When a patient comes to you and he or she following vegan diet, you must keep those things at the back of your mind, that these minerals are almost always deficient in in these patients, right? Gen Z's awesome. Okay. Now, one of the most vague thing I encounter while doing some questions is the back pain. Back pain is very uh, it's a different word if I talk about back pain. Now, so let's land on the ground of back pain. So you are having a patient, and she's saying or he's saying, let's suppose you got a patient of age 30-year-old, and the patient is saying that he's having back pain. Awesome. And now upon the examination, you encounter point tenderness over the vertebrae, or simply over some any bony protuberance on the back. And when you press those bony protuberance, let's talk about vertebrae, the patient is having some tenderness, right? Whenever you encounter something like that, think of Nothing else. Just think of that there is involvement of bony structure, and there might be something like fracture or some infection is going on. If the patient is feverish, of course he or she is having something like septic arthritis or something like that. Not septic arthritis, it's something called osteomyelitis, right? And if she's having some if she's having if you are suspecting the fracture, so she might be if you are encountering a female, so might be some osteoporosis thing going on, or if he's male, so it might be some fracture. There must be some recent history of recent trauma. Okay, now yeah. Okay, so now you got a female. She's about 55-year old, and upon that, she's also having back pain. Again, I said the ground of back pain got a lot of things going on honestly. Now, upon the neurological examination, you see no significant changes. Everything is normal upon the neurological examination. Also, she can walk, and she got no history of trauma. But upon the examination, again, you see some bony tenderness, some bony point tenderness. Whenever I say bony point tenderness, it means that upon palpating or upon pressing upon some bony protuberance on the back, the patient experiences some pain, right? That this is what I mean by your bony point tenderness, right? So a 55-year-old female is having some bony point tenderness. Or as I told you, everything is normal, everything is going on perfectly. But what's your diagnosis? It is stress fracture. She is 55, so she's in the postmenopausal state, and she might be having something osteoporosis going on. And again, as I've told you, that a stress fracture can occur in the postmenopausal woman without any recent history of trauma, right? So that's it. Okay. Oh. Hmm. You got a patient. She is 6 year old. For suppose you got a patient. If you are living in the United States, so you got a patient who is an immigrant, right? Not from US primarily. She's some immigrant. She's from something like I don't remember know the name of that country. I guess it's Bulgaria. I don't know how to pronounce. But she's from some country which is endemic, which is endemic of for to tuberculosis, right? And she came in this country when she was 13 years old. Now she is on now upon the clinical settings, you got a positive PPD test. Previously, when she came to the US, she got tested, and PPD was negative, right? But now she is having positive PPD, right? Again, let me tell you, she's immigrant. She came to the United States 13 years at the age of 13 years. PPD testing was done, it was normal. Now she's 23 years old, and you have done PPD test again, and PPD test, right? PPD test. So upon doing PPD test again at the age of 23 years old, she's having positive PPD test. What will be the next step in your management? You will do a PPD again? No. Remember, for the rest of your life, if the PPD is positive, it means that she got some TB in her body, right? Remember, for the rest of your life, you don't need to repeat the testing again. Even if it was negative some years back, but now it is positive, it means that TB is there, right? This test is highly sensitive for tuberculosis, right? Awesome. Another thing, that what will be the next step in your management? You will do the chest X-ray, right? And you will see that if there is any lesion of, that TB appears as a cavitary lesion, right? So you will see on the chest X-ray that if there is any lesion going on, if there is any lesion on the chest X-ray, if you see a lesion, then you will diagnose it as active TB. But if you don't see any lesion, then you will diagnose it as latent TB. Latent TB got a different management, active TB got a different management. I don't need to go into the detail of that at this stage, but you should know that how to diagnose active TB and how to diagnose latent TB. And again, they got a world of TB. This is a world of TB. Okay, awesome. Okay, I have written here for you that for latent TB, you go for 9th month treatment regimen of with isoniazid, right? Okay. Okay. Now some clinical questions regarding HPV, human papillomavirus screening stuff. It's just a simple question. For suppose you got a patient who is having yeah. So for suppose you got a patient who is of 24-year-old, right? Now previous he's vaccine he got all those vaccinations in the as of childhood, he got all those vaccination as of adulthood. Now is there any need for to screen for HPV? No, generally there is no need to test for HPV screening for those who are younger than 30, right? But if you are above 30, or if you are of course you will then go for HPV screening. And if you are some HIV, god forbids, but if you got something like HIV, then the guideline changes for those patients, right? Okay. This okay. You got a patient again, and he's 6 year old. I guess let's make him 7 year, but 6 year old is good enough, because let's say he's 6 year old. Okay. You got a patient who is 6 year old, and her his okay he is okay he we got he right, we got a boy, you got a 5 year old boy. And he came to the clinical setting along with his mother. And his mother says that the boy is toilet trained previously. And he was toilet trained at the age of 4 or at the age of 5, right? But now he's having consistently bedtime incontinence, bedtime urinary incontinence. Like he made the bad wet any every time in the night. So what will be the best next step in the management? Let me sum up this for you. That he is a 6 year old boy, right? Previously he achieved incontinence at the age of 5 year old, but now he's having incontinence, right? And he make the bad wet at the night. And that's it. So what would be the best next step in the management? You will first you will try some behavioral modification. Like you will what do we say, yeah, you will resist or you will limit the fluid intake in the evening, or just few hours ago from the bed. And you will suggest some bed wetting alarm or something, so those bizarre stuff. After that, even if the condition not improves, right, if the condition is at the same level, so then you will prescribe some medicine therapy like desmopressin and all those stuff, right? But first you will try behavioral. As in, what's the general golden rule for urinary incontinence in children? You will first try some behavioral modification, and then you will jump towards some medication regimen, right? So okay, this is my favorite question. You got a patient, she's 16 years old, and she loves swimming, right? She's just fond of swimming. She wants to swim everywhere, right? Okay, so she says, okay, she comes to the clinical setting. And upon examining her ear, her right or left ear, let's talk about her right ear, you see that there is pain with manipulation of the ear. And ultimately you diagnose that she is having otitis externa. You know what's the bug responsible for it? Yes, please, Pseudomonas, right? We all know about it. But what will be the best next step in your management? What will you do to reduce the number of otitis externa in this patient? What will you do? First of all, you will treat the condition acutely, right? You will give her some antibiotics that can kill those pseudomonas thing, right? Then you will say that okay, apply acetic acid, alcohol, I guess, alcohol acetic acid drops, right? If I'm right, and before swimming, and this is some preventive measure to prevent from back to back otitis externa in the swimmers. We also call this as swimmer's ears, right? Okay. Mm, okay, remember, if you are planning to sit in some NBME exam, again, if you are in United States, they play with you. Let me give you a question. A 55-year-old man comes to you and you ultimately you say that he is having some congestive heart failure, like he is having some not having enough blood pressure, or even if blood pressure is normal or something like that. Upon the chest x-ray you see cardiomegaly, upon the lung auscultation you can hear fine crackles, right? And the patient will complain that he is having nocturnal dyspnea easily. Whenever he lies, he got some breathing difficulties and all. So ultimately, it is congestive heart failure. Okay, what will be the best next step in management? Okay, no, this is not my question. My question is, what drug you will prescribe to improve the survival of this patient? Yes, please. What will you prescribe? You will prescribe ACE inhibitor or ARBs. Previously, I used to think that okay, I always used to mark diuretics for them. I always think of it that, oh my god, the patient is having a lot of fluid and we will just give them Lasix. No, it's not always the right answer. It might be an acute treatment, but for the long-term survival for CHF patient, always go for ACE inhibitor or ARBs. Remember, it's a golden principle. ACE inhibitors and angiotensin receptor blockers means ARBs. They are best for survival things. If you talk about some diabetic patient, ACE inhibitor ARBs. If you talk about some CHF patient, ACE inhibitors or ARBs. They are just best thing that is ever discovered from humanity, honestly. Okay, which is for suppose again, now another thing, you know, I just love to solve these questions, and I just love to discuss these things with you. And again, it is very beneficial if you hear this whole podcast till end. It is full with knowledge. Okay, for suppose you got a patient who is having some recent history of angina, right? And he's a smoker, chain smoker, but somehow he is committed to that, oh my god, my condition is so bad, and I have to leave smoking now, and it's very good for my health. Smoking is very bad for my health. Smoking cessation is good for my health. Okay, this is the patient perspective. You see, oh my god, okay, the patient is good to go, and you're gonna change the medication, and you're gonna some ultimately you want to have the patient. Of course, you're a doctor. Okay, so previously he was on some nicotine replacement therapy, right? But after some angina attack, the patient stopped taking nicotine replacement therapy. I will say NRT. The patient stopped taking NRT, right? And he started smoking again. What will you do? Smoking cessation? What will be the best next step in your management? What will you advise the patient? You will advise the patient that, my friend, nicotine replacement therapy is not contraindicated in heart diseases, like, right? You can continue nicotine replacement therapy even if you just had an angina attack. There is no contraindication. This is a myth. That's why I'm discussing here. Many people think, many medical student thinks, even I'm as a medical student, I used to think that nicotine replacement therapy is contraindicated in heart failure patient or in patient with some heart disease, but that's not something true. It's just a myth. And again, you can continue nicotine replacement therapy even after a day of just after an angina attack. There is no bad thing in that. And again, it's a superior therapy for smoking cessation. It's the best thing for patients who are smoker and those who want to stop smoking or discontinue smoking, right? Okay. Okay. Yeah. For suppose, this is one of my favorite questions. For suppose you are having some patient, and she is having some protuberance over the olecranon process. Okay, that's cool. You do you okay, the patient say, oh my god, this is very painful. Okay, and you also see some nodules on her big toe, right? You see some nodules here on the olectron process, and you also see some nodules on the big toe, and the patient complains, oh my god, these nodules and these things hurts a lot. What will be the best next step in your management? What's first of all, what's your diagnosis? Your diagnosis is gout. Of course, you see, whenever you see a big toe, whenever you something going on over olectron process, you always think of gout, right? Okay, it's gout. Perfect. Now you have diagnosed it. What will be the best next step in your management? What will you do to relieve the pain? Of course, you will go for you might be thinking of giving some NSAIDs, but no. Initially, the first drug to use in the patient of gout is colchicine. And for suppose your patient is saying that he's having a lot of diarrhea after taking colchicine, what will you do? You will stop the colchicine and then you will go towards acetaminophen. It's not an NSAID. Acetaminophen is not an NSAID, right? You will go for acetaminophen. Now, if the acetaminophen doesn't work. So if you go, then you will go for some NSAIDs. Now, if NSAIDs are not tolerated, then you will go for something like corticosteroids, right? So these are some acute management. I haven't mentioned any drug which I have not mentioned any drug here which is interfering with uric acid metabolism. Why? I haven't mentioned allopurinol. I haven't mentioned any febuxostat or something like that. Why? Because those drugs are for chronic management. All the drugs I have mentioned here previously are just for the acute management. So first drug for acute management is go for colchicine. Not tolerated, go for acetaminophen. So colchicine and acetaminophen are the first line. If you can't, the patient is not the symptoms are not relieved with that, you can go for, yes please, NSAIDs. If the symptoms are not relieved with that, you can go for corticosteroids, right? So this is the arrangement. Okay, now a 32-year-old female previously comes for a routine visit, right? And previously she had some cholesterol level of 280 or 300, right? She came to the clinic after 7 months. What will be the best next step in the management of this patient? What will you order first? You will order repeat lipid testing. Remember, if the patient has high cholesterol or high lipids, then the routine testing is recommended after every 6 months or 12 months, right? So the patient came to you after 7 months, you should say, okay, just go that those lipids thing done, then you will talk about the things. Okay, if I just want to modify these things a bit further, uh, we do repeat lipid testing after some significant life changes. Let me tell you this. Let me explain this thing again. Please give me some time to explain this thing. For suppose, when the patient came to you 6 months back or 7 months back, you see, oh my God, she's having 320 level of cholesterol. So you advise her some significant life changes like exercising, like having some good diet and some good things, everything, so like some good things. You advise some life changes. Even if you have prescribed statin her too, statins, right? You have prescribed her statins as well. But the major thing, you have done some significant life changes in her life regarding some lipid metabolism. Then she came to you after 7 months. Lipid testing is recommended. The guidelines are that please always repeat lipid testing in those patients in which you have done some significant lifestyle changes. Repeat the lipid testing after every 6 months to 12 months. That's the golden principle, honestly. Okay, Foosh, you know what is Foosh injury? Foosh, Foosh. It's like fall on outstretched hand. Okay. Which bone is most likely encountered in foot injury? Of course, scaphoid, right? Scaphoid is always like it's always doomed in the foot injury. Okay, so so now if a patient comes to you with foot injury and the boy is complaining that he is having some anatomic stomach tenderness, anatomic snuff bug tenderness, now you will think of what? You will think of some scaphoid injury. Now you have done some x-ray and x-ray is good to go, x-ray is fine. What will you do? You will observe and reassure the patient, oh my god, you are good to go and there is nothing to do. Will you do that? No, you won't do that. What will you do? You will first of all apply some cast, like thumb spica splint, right? And to avoid some complications like avascular necrosis. So whenever you encounter some scaphoid fracture, or you say just some scaphoid thing, so the first step in management, you apply a thumb spica splint, right? And then, but if somehow you encounter some non-union fracture or something worse going on in the fracture, you will go for surgery, right? Because you know that the blood supply, I can just sum up the things for you. The blood supply to the scaphoid is a bit unique, and we are always afraid of not having something bad to that blood supply. So that's why if we see some non-union fracture, we go for surgery. But if the x-ray is normal, x-ray is usually normal. So if the x-ray is normal or having some like effusion or having some like something like tenderness or something showing on some inflammation going on, so you will go for a thumb spica splint that makes the joint immobile for few days or few weeks. Then the patient is good to go, right? Okay, but for non-union fractures, you will go for surgery. If the things are well, x-ray is normal, you will go for thumb spica splint that immobilizes the joint for few days or for few weeks. Okay. Okay, now a man, an 80-year-old man came to you with some cognitive impairment along with his daughter. The daughter says that previously when her father used to drive, he got lost in many places, like, right? And 2 years ago he got lost in the market while driving somewhere. So it means that he's not good at memorizing the things or at ways, right? He's not good at judging the path, the roads, right? Okay, so what will you do? You will restrict the driving patient. You will restrict the patient from the driving until and unless the driving evaluation is confirmed by some safety companies, right? And then you will say, okay, the patient can drive. But until and unless the driving reassurance is provided by some safety companies, you just say, okay, the patient cannot drive the car, right? So it's not something that you encounter usually, so you can skip that if you want to, but it's something I have encountered in some exams. Okay, it's now first suppose if a patient comes to you, she says, okay, she is following no, if a patient comes to you, she says she's having fatigue and she's having some shortness of breath, and you order CBC. You see that upon the CBC hemoglobin is at 9, MCV is at 110, which and the labs were normal 2 months ago, but all this stuff happened just in 2 months. So yeah, so what which mineral or which substance or something like that is deficient in the patient? Which vitamin is deficient in the patient? Vitamin B12? No, vitamin B12 it takes air to develop vitamin B12 deficiency. You got a lot of storage in your body if the vitamin B12 get deficient, right? So which vitamin is deficient? Folic acid. Folic acid takes just months to develop. It just takes months to develop folic acid deficiency, but it takes years to develop vitamin B12 deficiency, right? Okay. Another important thing. Now, secondly, a patient comes to you and he is an older adult and he's saying that he's having a lot of time in his training while doing while defecation. Right? And in the bathroom he takes a lot of time, right, for passing the stool. Okay, and he is saying that he has developed these things for months, right? So what will be the best next step in management? Yes, you will. Okay, let me explain. Let me elaborate this case further. Uh, there is no tenderness upon the. I would say that upon the clinical examination, you see abdominal fullness, but there is no tenderness, nothing like that, nothing like peritonitis, and sorry, excuse me. um, yeah, and you see that he has not the weight is normal. He has not lost his weight in the past few months. Everything is good, everything is fine, and he is not having some blood streak stool. He is not having the fecal occult blood testing is negative. I can say this to make it more easier. And so ultimately there are no red flags. Yeah, we can say that. So if you encounter any chronic constipation patient, and he is an adult, or you can say a patient with older age, like some 60s or 70s, right? So more appropriately 70s to 80s. Guidelines talk about 70s to 80s, and he is having some chronic constipation. So you will always first of all talk about or think about some fiber supplementation, right? Imaging, again, imaging like chest x, like abdominal x-ray or CT scan, these things are reserved for only those patients who are having some alarm signs or red flags, right? Right, again, if I say that if he is having some positive fecal occult blood testing, then you will always go for a colonoscopy for suspicion, right? So again, uh, in the imaging, you got colonoscopy, you got abdominal X-ray, you got CT scan, you got endoscopy, you got ERCP, and all those stuff. But again, no red flags, no imaging, just give fiber supplementation, and the patient is good to go. Okay, that's the last. Okay, in an okay, a patient comes to you, and she says that her father and her mother, and her like grandparents, and all those people, they got papillary thyroid carcinoma diagnosis, right? They got something wrong with their thyroids. So, and the patient comes for a routine visit and nothing more. And now the patient says, or the patient asks, that if she or she is supposed to undergo any diagnostic testing or not. So what will you do? Again, let me tell you, the patient is normal on the examination, normal on the labs, on her previous labs, everything is fine, totally fine. What will you do? You will just palpate her thyroid glands and nothing more. Just palpate thyroid glands. There is no need for imaging, nothing like that. But if you, upon the palpitation of thyroid gland, you see some nodules or something like that, you might order some ultrasonography. But again, that's reserved for red flags. First of all, let's do some palpitation. If you get something negative or something alarming on that, then I would say that you should go for ultrasonography. But everything is fine, there is no need to do. Okay, well, there are some more things, and I want to go into detail of that. Let me just give you some an algorithm regarding thyroid cancer risk. Okay, asymptomatic, no family syndrome, no family syndromes, right? She is not having some family syndromes. What is family syndrome? Like having some MEN, multiple endocrine neoplasia thing, or like having some Lynch syndrome type things. Lynch syndrome for colonic cancer, Lynch syndrome for ovarian cancer, right? So again, she is asymptomatic, no family syndrome history, but some family members got some papillary thyroid carcinoma. So what will be the first step? First step, we will do palpitation. Now, if you see some suspicious physical finding, you see some nodule, you see some asymmetry, you see some film mass, then you will go for ultrasound. Upon the ultrasound, if you see some suspicious nodule going on, then you will go for FNA, fine needle aspiration biopsy, and that's it. Yeah. Upon yeah, that's it. Okay. Yeah, that's it for today. Well, I got something more for you, but I think that's enough, and I gotta go as well. So that's it for today. I hope that this video makes you things understand in a better way. And again, these are some golden principles that I have just collected from some certain appropriate things. There is no AI. I haven't contacted or I haven't prompt chat GPT for that. I just made these things, these bullet points by myself. If you want these points in the form of notes, if you want these points in something like some sort of handouts, you can just contact us on our Instagram page. And that's it for today. Wish you a good day. There is night in the Pakistan right now. I don't know what's going on your side, but have a good day. Eat good, live and spread peace. Thank you.